Hi, it's Dr. Centeno, and thanks so much for joining me this morning. We moved this around a little bit. I know I was doing Thursday mornings, and now I'm on a Friday morning. So hopefully this next one will be on Thursday morning. Just still trying to figure out the best time for me and for everyone else to do this. So today, got an interesting topic: why CCI patients kind of bifurcate into two groups, CCI only and CCI and something else. And what's interesting about this is I've seen this many, many years where patients come in and they're pure CCI patients, and that's all they've got. It's very clear on their hands-on exam. There's nothing else going on. It's just CCI. And then there are patients that come in who clearly have something else going on as well, right? It's commonly in the lower neck or in the shoulder or in the upper back or the lower back. And while some of those things are tied into their CCI, some of them are quite separate issues. So we're going to explore that today a little bit. Now, as I always say, if you can get your comments in wherever you are early, then I'm more likely to get to those questions. The problem usually is that I have more questions to answer than I can get to during a 1 hour time period. So just try to get those in right now. If you're on Facebook, you can just put your question in the comment. I'll see it here. If you're on YouTube, you can put your question in the comments. I can see it here as well. But if you get those in early, then I'm more likely to be able to get to your questions. If you get them in later, then it's less likely I'm going to be able to get to those questions. So again, if you're just joining us, we're going to be talking about this bifurcation of patients who have CCI who are either sort of CCI only or they are CCI plus something else, and whether that makes a difference and how it affects things in treating that CCI patient. After that, we'll go through extensive Q&A. So if you've got questions, put those in the comments right now. And that way I'll be able to get to those questions. So let's get started here on this topic. So I've noticed recently, again, that one of the challenges in measuring and tracking outcomes in CCI patients is that they kind of exist in two distinct groups. We've got a CCI only group, and we've got a CCI plus something else group. And the CCI only group is very clear, right? I can tell on hands-on exam, they've only got tenderness in their upper neck, all of their symptoms are upper cervical, and they have CCI on imaging. They respond in predictable ways to predictable treatments, etc. And then we've got the CCI plus something else group. And that group's a little different, right? They come in on physical exam and they've clearly got upper cervical CCI symptoms, but they've also got other things. So commonly, let's say a lower neck disc bulge that's pretty big. And then it also appears to be causing symptoms. So again, I've got this two patient groups here, and they respond a bit differently, or at least I have to treat them a bit differently. So what are the common something else problems? It's usually the lower neck. This is a separate problem that we often treat that may or may not fully respond to regenerative ejection therapy, but can also commonly be a separate shoulder, low back, rib, upper back issue, etc. So why do these patients behave differently in treatment? Because again, the focus of a PICL procedure is going to be on those upper cervical ligaments, and then we're going to add in other treatments that are upper cervical in addition to that. So that would be doing the posterior ligaments as well. That would be doing the upper cervical facet joints. That might be treating the vagus nerve under the SCM, or the superficial cervical plexus, or the greater occipital nerve, or the lesser occipital nerve. All of those different things, though, are focused on the CCI as a disease complex. Whereas when someone comes in with an upper and a lower cervical issue, we're certainly going to treat that lower cervical issue, But it adds another dimension, right? A whole other thing to think about in what it is we're going to treat. And sometimes I will tell patients, listen, you've got a pretty severe shoulder issue here, for example, and I can give you the name of some doctors who I trust locally who can treat your shoulder. But at the end of the day, it's important to understand that your shoulder's not helping your neck, and we'll treat your shoulder a bit, but you're going to need more extensive shoulder treatment than I can provide. So if I can treat the other area, I will. If we have enough stuff to treat it, if there's enough time to treat it, etc. And I tend to treat the ones I believe that are involved directly with their CCI. So what I mean by that is that other area isn't helping the CCI. The fact that they can't use their shoulder really well is sort of hurting the neck. And that makes these something else patients a little more difficult to treat at the end of the day, because we're focusing on the upper neck and most of the treatment is focusing there, but we're also doing some treatment in these other areas. Now, again, does that mean that we ignore these something else areas? The answer is no, we definitely don't ignore these something else areas. Most of the time, I'm treating those areas as well. And I'm treating those areas as well simply because I believe that they're connected in some way. Now, for example, it's very common for patients who have chronic neck pain to develop chronic back pain. We know that patients with chronic neck pain have a problem with allowing their lumbar stabilizers to work or coordinate. So that makes sense, right? You might get the lumbar stabilizers to go offline. That then causes a separate low back problem, etc. In that case, I will treat the low back as part of treating the CCI. But at the end of the day, it's critical to understand that this does create a little bit of a sideshow, right? My focus is the upper neck on the PICL. I will treat these other areas if I possibly can. And however, they tend to be second in priority to getting their CCI sorted. So there will be some times where I actually ask the patient to go get that treated elsewhere. Now, if we want to just do a quick look at this idea, and it's probably a question that most people have, is do the CCI plus something else patients have a different outcome trajectory? Now, if you were to ask me, I would say probably, meaning without looking at the data, but I pulled some of the data from the As Seen case series this morning. And as you can see, these are all patients who have everything. And these are patients who are filtered based on a low back and SI joint problem. A lot of patients in both groups here. And ultimately, those curves look pretty darn similar. So at the end of the day, there doesn't appear to be a big difference between those two. The medians are about the same. So ultimately, I would say probably not. There's probably not a difference here. So in conclusion, CCI-only patients are easier to treat. CCI plus something else patients can be harder to treat. And we don't know if the something else reduces outcome. It's possible that it could, and there are probably specific times where it does. So for example, I know that if someone's got a very large lower cervical disc bulge, that lower cervical disc bulge is pressing on the spinal cord, that may need a separate surgery. We'll certainly treat it when the patient's in there, but they may need to get that surgically taken out to reduce the pressure on the spinal cord. So just realize that among many patients, there's probably not a huge difference in outcome, but in specific instances, there probably is a difference in outcome. Okay, well, let me get rid of that and we will start to answer some questions here. See some questions coming in. Again, no matter where you are, whether you're on YouTube or Facebook, you can, if you've got a question for me, just go ahead and put it in the comments. Try to get that in earlier rather than later. So just put your question in the comments. Hi, doctor. What will you recommend for a patient that has maybe gotten good improvement from one EPICL, but still not completely asymptomatic, still repeating 4 to 6 months will be wise? Yeah, so on the second PICL or subsequent, we generally recommend that those are repeated every 4 to 6 months. And I was just looking yesterday at that As Seen case series because we record now when the patient had their last PICL. And it's interesting. There's a lot of patients that do come in at that 4 to 6 month mark. So again, patients kind of bifurcate there. We've got the folks that come in at the 4 to 6 month mark, and we've got the folks that come in later. But about 60% of them or so, and I'll run those numbers here at some point, are in that 4 to 6 month mark, and that's what's recommended as far as that second or subsequent treatment. E. Smith, could Montana's new right to try legislation, which allows experimental drugs to be used theoretically, allow for stem cell culture, PICLs, or other new orthobiologic treatments in Montana? It's possible. It's all still federally illegal. Florida has a right to try law. The FDA has sent warning letters to clinics and manufacturers in Florida who are trying to use those treatments according to, quote, Florida law. Now, in my opinion, the Florida law is pretty weak and flawed. In fact, I tried really hard to work through some of the medical societies there to inform the legislature that they had some problems. But regrettably, it kind of turned into the Wild West, even though it's the Southeast in Florida. As far as Montana goes, certainly possible that someone in Montana could try to use culture expanded cells. The problem is that may be legal in the state, but it's federally illegal. So we'll see what happens there. I think much will depend on which direction sort of Congress heads here in November. And in addition to that, realize that, the PICL is not about magic stem cells. It's not a magic stem cell procedure. We use bone marrow concentrate, which has stem cells in it. But really, the thing that makes the PICL work is, number one, a doctor who can understand what needs to be injected. Number two, a doctor who has the experience to get those cells in those specific spots with high accuracy and lowest risk possible. And so it's really the second part, that part of getting that stuff where it needs to go, that is the trick. So just culture expanding the cells probably isn't going to add very much because I've used culture expanded cells now for 20 something years. I've got the world's largest or certainly oldest experience in using culture expanded cells in orthopedic and spinal conditions. And they can add some things, but they're not magic either. So again, our clinic can take someone down to Grand Cayman, use culture expanded cells at will. We don't usually, because it's not magic. It can add some things, but it doesn't add magic. Dayron, doctor, how will a neck bulge respond to facet joint injections? Usually a neck bulge, well, probably best to say it this way. A neck bulge is a symptom of a degenerative spinal level. A degenerative spinal level can have decreased disc height, which puts more pressure on the facets. Then those facets can become arthritic and painful. So in that case, treating the facets may give someone great relief. In addition, if the facets are in the middle of the neck to the lower portion of the neck, then they usually leak into the epidural space around the nerve. So you kind of get a twofer when you inject the facets. You get not only the facet joint treated, but you also get the interface between the bulging disc and the irritated nerve treated as well. So in most patients who have neck disc bulges and pain, facet joint injections under C-arm fluoroscopic guidance with contrast confirmation and confirmation that you got into the epidural space through that overflow mechanism will probably help. Mark, I've read that ginger supplementation hits the same COX-2 switch as ibuprofen, but spares COX-1. Would this be a problem during recovery from orthobiologic treatment, similar to taking an NSAID? I'm unsure which COX pathway is problematic during inflammation stage of recovery. Thanks. Yeah, so it's probably better. I think you've got those backwards there. Ibuprofen, I believe, hits COX-1, and the COX-2s are things like Celebrex. But ultimately, realize that most of those supplements are really acting more on the LOX pathway and through things like resolvins. So resolvins are, for example, present in fish oil. Fish oil has resolvins that can resolve inflammation. That's a different concept than blocking inflammation. So supplements do act differently, but you might be cautious with ginger and maybe use something like high-dose EPA fish oil in order to help, because that's going to work more on the LOX pathway, and it's going to have resolvins, which can resolve inflammation. Hi, doctor. Do you have an update on proving that swollen bursa theory causing pressure headaches at the moment? Which theory do you think is most likely, vein compression, bursa, or something else? Yeah, I thought quite a bit a couple of years ago, maybe 2 years ago or something, on how I would test that out. So let's unpack that a little bit. What we're talking about there is the idea that for the most part, when people have pressure headaches, it's chalked up to decreased CSF flow, increased intracranial pressure, etc. Having said that, we see a lot of patients who have pressure headaches, and it seems to be coming from a swollen upper cervical bursa. Now, regrettably, the only way to test it would be to just inject the bursa, but just injecting the bursa requires an anterior PICL approach. So ultimately, it was decided that that was too high risk in order to just test out the theory that the bursa was causing their headaches. So I don't know that anyone, as a result, will ever figure that one out. But I can tell you that in most of the patients we see, a lot of that pressure headache is coming from one of these swollen bursas. E. Smith, what type of CCI would create symptoms when laying down on your back? I don't know that I can get to a specific type of CCI. Some of the things you might think about would be if there's a skull sliding type CCI or a CCI type 1C. That's a common complaint of some of those CCI type 1C patients. And that makes sense because the pillow will put pressure on the head to slide forward. So that's something to think about there if you have that kind of problem. Now, how would you get to a CCI type 1C? Best way would be an upright MRI with flexion extension views, more so than a DMX. Jessica, I had my first PICL with you Monday. Right now, I'm dealing with slipping rib syndrome. Will that affect me for the procedure? No, Jessica. I mean, that's something that I'll definitely take a look at. Slipping rib syndrome is actually pretty easily treated through direct injection. That's one of the things that always kind of gives me a head scratcher, that you've got a slipping rib syndrome community, which is very focused on getting surgery for this. But rib instability responds very, very well to prolotherapy, PRP injections, bone marrow construct injections. So we can talk about the risks and benefits of adding that in to your treatment and whether or not that's appropriate for where you are in your treatment cycle. Tiffany, how does the immediate post-procedure period look for PICL alone versus PICL plus other areas? Probably not. Well, if we're talking about upper and lower neck, probably not much different. In fact, the patient may get some sooner relief with the lower neck simply because we would be putting some of those platelet growth factors, which are anti-inflammatory, around the irritated nerves. Having said that, if you extend out to other things like problems in the shoulder, and we use bone marrow in the shoulder can cause a lot of post-procedural flare-up. So that person in particular may be more miserable than the average PICL patient, because they're not only dealing with this, but they're dealing with quite a bit of swelling and pain coming from the shoulder. For the back patients, again, just another area. It's going to be here and down there, but probably not all that much different. Lindsay, do you recommend seeing specialists at the same time we are receiving PICL treatments? Would we have enough stem cells for both doctors? Is it better to wait until we finish with PICL treatments? I'm not quite sure what kind of specialist you're talking about, Lindsay. The cells that we take, the bone marrow concentrate that we use, which contains stem cells, is critically important that that is single use, meaning that's the law. So we can take the bone marrow aspirate, we can concentrate the stem cells in that bone marrow aspirate and create bone marrow concentrate. We can use it, but it has to be used in the same day. So you can't take those cells out of the building at all. If you're talking about seeing other specialists in other areas, let's say someone to treat your neck and your shoulder, then that's A-okay. Obviously, you'd want your neck to calm down and then get your shoulder treated. Are you currently also looking to other kinds of treatments for CCI exosomes, peptides? Thank you, doctor. Yeah, so Tomito, maybe. So ultimately, the answer is we've looked at all of that, and there's none of it that's really real at this point. Exosomes, the most common exosomes that are on the market are basically ultracentrifuge baby urine. And what I mean by that is that amniotic fluid in the last trimester is mostly urine produced by the baby. Now, it does have some growth factors. And as far as concentrating the exosomes, what I would buy has nothing to do with anything, meaning that exosomes are just messages. So if I ultracentrifuge that amniotic fluid, I can kind of maybe get to a layer that has more exosomes or messages in it, but I don't know what those messages are. Are those messages good, bad, indifferent? Meaning those messages could be repair. Those messages could be destroy yourself as another cell, which is critical in that whole process of tissue repair. Those messages could be mutate to a cancer cell. So until we actually have exosome products, including the ones derived from culture expansion, where we can pick out the messages we want, and we are nowhere near that. Exosomes are more hype than anything. And peptides, again, A, I don't know if I'm actually getting a real peptide, and B, if I am getting the real peptide, is it biologically active? Because no one's done any test on that. For example, one of our companies is working through FDA approval right now, and it takes a year just to and millions of dollars just to dial in the manufacturing process so that you can manufacture the same thing that has the same biologic activity time and time again. So peptides don't go through that. So no, not going to use any of those anytime soon. Matt, I have problems in my neck, and every MRI scan I've had shows no issues. What can I do? Heard of a DMX scan? Is it worth doing? Thanks. Yeah, Matt. So there's a couple different layers there. The first is that realize that a neck MRI scan is only going to show things like disc bulges, whether the facet joints have arthritis, etc. And that's what the radiologist is going to read. Now, there may be other things on that MRI scan that weren't read that are important. So that's the first thing. So, for example, deep muscle atrophy is an important finding, but it's not usually read. So that'll be read as normal. The second thing would be, is there instability? So that's what a DMX would do, or an upright MRI with flexion and extension. that would add movement into the equation. So you could see whether or not something is unstable and moving too much, which is not going to be shown on a routine neck MRI. Lindsay, are stem cells found in hair follicles? And if they are they useful for anything? There are different kinds of progenitor cells in hair follicles, but I don't know that you would find there the kind of stem cells that you could easily use for tissue repair in the musculoskeletal system or the spine, for example. Hey, everybody, if you could do me a favor, give me a like and a subscribe, no matter where you are, whether you're on Facebook or on YouTube, simply because at the end of the day, that's how other patients find this video. And that's a way you can pay it forward in the CCI community to other patients who are searching, desperately searching many times for information. What do you mean when you said concerning lower neck issues, that those issues don't usually respond to regenerative medicine treatments? You may have said those issues don't always respond. Yeah, so what I mean by that is that that's going to depend on what's in the lower neck. So for example, I think we were talking about the situation where we have an upper neck craniocervical instability at the same time that we have a lower neck problem. Now, if the lower neck problem is, simply a little disc bulge, some degenerated facets, some degenerative instability, then that's easy to treat with orthobiologic injections. But if the lower neck issue is a huge disc bulge that's indenting and putting lots of pressure on the spinal cord, then that may or may not respond to orthobiologics. So now we've got a patient where we can fix the upper neck and help them here, but I can't do anything down there without them getting a surgery to take that disc bulge out. E. Smith, could sleeping in a bad position, like a side bend, stretch ligaments in the neck? Yeah, it's possible that it could. I think when you sleep, there's a couple of things that you should think about. The first is keeping your head in line with the rest of your body, and that's not easy to do. Most pillows that you can buy in the store will bend your neck. So getting a pillow that you can mold to make sure that your neck and your body are in that same plane is important. The second thing you might consider doing is if you really have a hard time with waking up and it's because of your neck position at night, then you might consider using a cervical collar at night, a really comfortable one, like a soft collar. It's not going to impact your muscle strength very much if you just use it at night, but it may help you get to sleep and get some restful and restorative sleep. Jessica, I also have my posture screening at 10:40 with Todd Bay today. Well, congratulations, Jessica. Todd's a good guy, and he's been working hard to understand and help our patient population for quite some time. Trista, why does there seem to be disagreement between if CCI is an actual recognized condition? Some doctors think it's real and an issue, and then some think it's a type of neck issue that would cause symptoms like don't think it's the type of neck issue. Yeah, so Trista, this is a highly specialized area. So for example, if you go to one of the handful of surgeons, neurosurgeons around the world that do this work, and Dr. Goel, Dr. Bolognese, Dr. Patel in South Carolina, Dr. Frank in Florida, Dr. Henderson in Maryland, Dr. Oliver in Barcelona, Dr. Gillette in Barcelona. Those doctors know this area well. They'll be able to rule in or out CCI and tell you what's going on. They may offer you a surgery. They may say do something like a PICL first, but the area is specialized enough where you need to find one of those experts. And that's not dissimilar from other relatively rare conditions, right? If you had a rare type of cancer, you might have to go to the Mayo Clinic to find a guy who really understood that rare type of cancer, who has seen hundreds and hundreds of cases and knows how to treat that really well. It's very similar with CCI. Had 2 EPICL, gave foundation for improvement now in cervical strengthening with vision. Vestibular PT, need time to see what improves with these, but is waiting more like 6 to 11 months for the next PICL. Bad. It's not necessarily bad. We have patients that do take longer to heal, and that's okay. It seems to be on average about maybe 3 in 10 of our patients. And so they would really do well with waiting that 6 to 11 months. Now, realize that we kind of had a natural experiment, and I've said this a couple times during COVID. And what happened during COVID is we had patients who either wouldn't come in or just couldn't come in and couldn't travel. And so all of a sudden they were on that about every 4 to 6 month time frame, and that got shifted to 1 to 2 years. And we had about half of those patients that held their gains, about half of those patients that regressed a bit. So that's the best I can tell you, but you probably know your own body better. And if it feels like you're making progress with what you're doing, you may want to take some extra time. Lindsay from Utah, is it safe to use Botox between the eyebrows for migraines? Yeah, Botox between the eyebrows for migraines is probably not going to be a huge deal. It would really be Botox in this area at the back of the neck or upper traps or sternocleidomastoids that would be a bigger deal in this kind of procedure, right? Because Botox works by relaxing muscles. Now, if we relax a muscle too much, what can happen is that person can get less stable. And we're trying to make that person more stable. But Botox between the eyebrows for migraines, probably not going to move the needle very much on what it is we're trying to accomplish. Preston, would cervical spine decompressing using a traction device at a chiropractor's office to treat a bulge at C5 be contraindicated in a patient who has CCI and has received several PICLs? Yeah, probably not a great idea, Prescott. That's kind of ultra or super traction. And what ultra or super traction means is they tend to pull harder and have certain cycles that they pull. So that's going to pull on the ligaments that hold the head on. So it's probably not an ideal thing for someone who has CCI or is trying to heal from CCI. Sam, on a standard MRI, the report said I had insignificant disc bulges measuring 1 millimeter at C456. Do you think if I were to get an upright MRI, it would reveal a more significant measurement? It could. Sam, I have seen some cases where the disc bulges didn't really show up on a standard supine live face up in a tube MRI. But they did show up once you added the weight of the head into the equation. Also realize that an upright MRI, hopefully they get you into flexion and they get you into extension, which can also make some of those disc bulges show. So upright MRI, if you really suspect a disc bulge as the cause of your problem, with flexion and extension is usually a really good next step. E. Smith, can autoimmune disease make someone ineligible for PICL? Well, yeah, a lot of that depends on what autoimmune disease. So, for example, we have a lot of patients who have what I would call alternative medicine autoimmune diseases, right? Things like CIRS or mold illness. And they don't seem to respond any differently than other patients. Now, then there would be the hard autoimmune diseases in there, like things like lupus. Well, some of the lupus patients can get sick enough where we might be very concerned about doing a PICL, or severe rheumatoid arthritis that is affecting the upper cervical spine or has been aggressively treated with biologics. Hence, it's hard to mount a healing inflammatory response. So just realize at the end of the day, it really depends on the type of autoimmune disease that we're dealing with. Kimberly, hi, Dr. C. What is your thoughts on using PRP, the kind that's used in the so-called cosmetic world, hair face? I'm not quite sure of the question, Kimberly. The first answer to the question, just want to make sure I can encompass it or get it, is that the concentration of PRP used in those clinics is usually very poor. That's a cash service that's very competitive. Clinics compete on reducing fees as a commodity. So they tend to buy PRP kits, which are the cheapest possible, usually the ones that come bootleg from China. And those can only get to very low concentrations of PRP. So if you're middle-aged or older, that's not going to work really well for you. If you're talking about whether or not PRP can help things like hair, yeah, there's a bunch of randomized controlled trials showing that PRP can help with hair density and hair growth. In fact, I think this next week or the week after that, I'm going to get some. As you can tell, I got a little bit of thinning up here. So Dr. Pell is going to do my scalp. And he's already done one of the doctors in the clinic. I don't want to betray any confidences, but that doctor has seen some good results. They showed me the results. So again, for things like hair, skin, facial stuff, there is data for sure. Trista, if you have several scans between DMX, static MRI, flexion extension X-ray, and they didn't measure things like grab oaks and other important to determine the severity of CCI, can someone request a reread by another radiologist? Can we have them read by someone more knowledgeable? Yeah, so the first thing would be that X-rays and a static MRI wouldn't be the best place to measure things like grab oaks. The best measurement for things like grab oaks, clivoaxial angle, BAI, BDI, Bayesian axis interval, Bayesian Dens interval, is really an upright MRI with flexion and extension. So getting those measurements on a standard MRI is going to be much less helpful. It's going to be very hard and with much less accuracy to get those measurements off a DMX or an X-ray. Now, any radiologist should be able to, for example, give you a grab oaks measurement off of your MRI, but I don't know how much that's going to mean, because really, if you're looking at those kinds of neurosurgical measurements, the best way to get them in 2026 is an upright MRI with flexion and extension. Tomito, I had my first PICL with Dr. Schultz recently. Pressure headaches, which is my primary symptom, have since quite flared up. Is that indicating that the bursa is the primary cause for it? Could be. It's possible. I can't say for sure, but yes, you would expect that there'd be some swelling in that bursa, and that could increase pressure headaches. Carol Yates, submitted advanced by Harry Winston. Is it important to get other issues in neck and upper body treated before the PICL? No, Harry, it's not necessary to get them treated. Like I said, if they're connected and we're not really on a wild goose chase, if you will, of trying to treat this or that, then we can certainly try to treat those when you get a PICL. Now, having said that, if you've got a big problem like a torn rotator cuff and it's really bothering you, and you've got someone locally who can treat it very easily, and you're months out from your PICL, then by all means, get it treated. E. Smith, could Smurulin improve stem cell or PRP outcomes? Smurulin is a human growth hormone releaser, if you will. It's one of the peptides. And, the good news about Smurulin is that it can increase HGH levels. The bad news about Smurulin is it tends to wear out after a time period. And the other bad news about Smurulin is that then tends to add weight to the patient. So I think you need to be a little careful there, because if you're adding weight, meaning fat, to the patient, then that's going to, in this case, be because of blood sugar instability caused by higher HGH levels in an older person. So Sommerlin usually would be combined with things like metformin to control that blood sugar spike. So if Sommerlin ends up just increasing HGH levels without also putting on fat, then that could be helpful, potentially in a stem cell or PRP outcome. But you'd have to thread that needle very, very carefully. There would probably be much better ways to do that. Things like one of the GLP-1s would probably help stem cell or PRP outcomes even more, as long as that person did not become protein insufficient. And that's a big problem with GLP-1. So these are complex questions. Dayron, doctor, do you usually see neck disc bulges reabsorbing after getting stability after EPICL? Yeah, a neck disc bulge generally doesn't get smaller with time. Now, a herniated disc can, and some types of disc bulges do as well. But EPICL wouldn't have much to do with the neck disc bulge. It's going to be focusing on the hypercervical spine where there are no discs to bulge. JS, can you clarify why a patient needs surgery for a bad disc before you can fix CCI? Yeah, I didn't say that. What I said is that if they've got a specific type of disc and that disc is very large and putting pressure on the spinal cord and the lower neck, then we will try to treat it when we're doing the CCI and doing the PICL. We'll also treat that area. But if that lower neck doesn't respond to orthobiologics, then that person may need neck surgery down here, independent of what's going on up there. Krish, punch bones affecting any area, but including treating very words, doctors. Not quite sure what that means. Hi, Doc. Howdy. Do people get back to playing soccer, basketball after having CCI? It's possible. We certainly have patients that have gotten back to high-level physical activities. A lot depends on where the patient starts. So if you're a bed-bound patient who's spending 23 hours a day in bed, the likelihood of you getting back to soccer or basketball is very small. If you're a high-functioning patient who just sort of lives in a functional box to control their symptoms, then the likelihood of getting back to soccer and basketball is much higher. So it all depends kind of on where you start functionally. Rake, hi doc, do you think insurance companies will start covering this treatment in the near future? Neck-related issues are becoming increasingly common and more patients are becoming aware of their issue. I don't, Rake. The good news is through the Regenix corporate program, we have coverage now for, I think it's about 3,000 companies. So those tend to be mid to large size companies where this stuff is covered, including lots of different orthobiologic treatments. That's because those companies can save money by moving people from the surgery column into the non-surgical column. Having said that, the likelihood that something like a PICL treatment will get wide insurance coverage anytime soon is extremely small. And that's mostly due to institutional momentum and the way our US system works. Krish, I need, yep, don't know what that means, Krish. JS, can PRP treat a bad disc bulge pressing into the spinal canal? Yeah, JS, so I think as I've said, that's a functional spinal unit issue, not necessarily a disc bulge issue in most cases. So in most cases, you're dealing with a sloppy segment with arthritic facet joints and a pissed off nerve and a disc bulge. You can treat that whole segment and help those patients quite a bit. But you're not trying to get the disc bulge smaller because the disc bulge is only one tiny bit of the equation that's causing symptoms. Trista, So sorry, last question. How do you grade the severity of CCI? You have mentioned different classifications like A, 1B. Yeah, so we have a grading or a typing system that looks at where the CCI is coming from. And so, for example, a CCI type 1A would be too much rotation of the head and a low clivo-axial angle. A CCI type 2A would be an increase in ADI due to a loose transverse ligament. A CCI type 2B would be alar accessory, allowing too much C1, C2 lateral overhang and lateral bending. And then you can go to mild, moderate, severe. But the problem with using mild, moderate, severe based on imaging is it doesn't always correlate to the severity of the patient. So we tend not to like to do that. I think it's better to use mild, moderate, severe, looking at how severely impacted or disabled the patient is or isn't. Krish, MRI scan. Okay, I'm going to skip those. Okay, guys, I think I am at my last question there. So I'm going to start to wrap this up. I want to thank everyone for spending so much time today and asking these great questions. Again, I always say that great questions are how we all learn. So thank you for doing that and for showing up this morning. We'll figure out the time of this thing and get it all settled at some point. I think I just saw a question there. So I'll answer this one. Patricia, this will be my last question, guys. Patricia, hi, Dr. C. Can you elaborate on the success of EPICL with those with mild scoliosis? Would it be advisable to do PT to help with T-spine before? Yeah, so as far as the success of EPICL with mild scoliosis usually doesn't make a difference. There are some patients that will ask to do sort of left-right scroth therapy, which can become important in balancing out the body. So at the end of the day, a mild scoliosis is probably not going to affect the outcome of an EPICL procedure. But when we get into more significant scoliosis, moderate, severe, it's more likely to. And if you have a mild scoliosis, something that you should consider looking at is PT like Scroth, where they're looking at that left-right balance of the body. So that's really kind of where you should start. And obviously, I will tell you, as your doctor, whether or not I think your scoliosis is impacting your recovery. Okay, guys. Well, thanks so much for joining me this morning. I really appreciate everyone's time. And I'm pretty sure we'll be doing this next Thursday based on how things are flowing. And I will see you with another topic to talk about at that point. Thanks so much for joining me.